This case illustrates the evaluation and correction of the diagnostic guide using the guideright protocol and 3 different software programs to determine the angle of correction needed. Ridge augmentation is completed with infused bone graft using minimally invasive VISTA approach. We are replacing the mandibular incisor and completing a minimally invasive ridge augmentation. After the implant is placed, number 25 is moved lingually into position. We are using 3 different software programs to evaluate the implant placement. The treatment plan is to replace number 24 and reposition number 25 while the implant is integrating. The first step is the fabrication of the diagnostic guide. An impression of the patient's arch is taken and a cast of the patient's arch is poured up and allowed to set. Slurry water can be used for faster set times. A 3/32 drill is used in a laboratory handpiece to place a hole in the cast to indicate the location and vertical axis of the prosthetic planned implant placement. A straight 2-piece guidepost was used to place a 2 mm diagnostic guide because of the narrow space involved. This is a frontal view of the cast illustrating the use of the 2 mm guidepost and 2 mm diagnostic guide sleeve. After the cast is lubricated with petroleum jelly, Triad gel is used to capture the cleat and the adjacent teeth to form the diagnostic guide. A cone beam radiograph is taken with a guide in place for the 3D evaluation of the diagnostic guide in 2 planes, mesial-distal and buccal-lingual. Three software programs were used: InVivo5 by Anatomage, Blue Sky Bio, and CareStream Dental. The first step is to align the dental arch plane in each of the software programs. The next step is to align the virtual implant of the appropriate size with the long axis of the guide sleeve. On the right, I have scanned the cast with the CareStream 8100 and merged the scan with the cast, which indicates the long axis of the prosed osteotomy made with a 3/32 drill, indicating the axis of the home position. The home position indicates where the osteotomy would be if the 3 mm diagnostic guide sleeve is used without corrections. The mesial-distal angle of the guide sleeve is acceptable as it is, so no correction is needed in the mesial-distal plane. Next, the long axis of the guide sleeve will be evaluated in the buccal-lingual plane. One can see that the implant would be angled too far labial if the angle of the diagnostic guide sleeve is not changed. The long axis of the implant is rotated lingually, so it is centered within the bone with each of the software programs. The angle tool is used to measure the angle between the long axis of the guide sleeve and the long axis of the virtual implant, which measures 12 degrees on all 3 programs. The correction will be made with a straight 2-piece guidepost by bending it 12 degrees toward the lingual with the guideright bending tools. The components of the bending tools are illustrated here. The correctable lower part of the guidepost is placed in the stylus with the registration dot on the square platform exposed. The set screws are tightened against the sides of the platform of the guidepost and the stylus with a 0.035-inch driver with a black and red handle. The stylus and the guidepost are placed on the platform of the bending plate. The lower half of the straight two-piece guidepost is inserted into the rectangular slot of the stylus. The two set screws are tightened with a black and red 0.035-inch hex driver. The guidepost held in the stylus is inserted into the rectangular block of the bending plate. The 5/64 hex driver is used to tighten the cap screw against one of the sides of the guidepost. The 12-degree correction is made with finger pressure by bending the stylus to the 12-degree mark. The cap screw is loosened to release the stylus and the corrected guidepost. To release the corrected guidepost from the stylus, the set screws are loosened with a 0.035 hex driver. Question: how accurate is this method if the correction is off by 1 or 2 degrees? The answer can be determined by using the Pythagorean theorem. The tangent of an 11-degree angle is 0.19. The tangent of a 12-degree angle is 0.21. The difference between the two angles is 0.02. If you multiply 0.02 times the length of the 10 or 12 millimeter implant, the magnitude of a linear change at the tip of the implant is 0.2 to 0.24 millimeter. Therefore, 1 degree error is not clinically significant. The next step is to make a new guide using the 12-degree corrected guidepost. Next, the cast is relubricated and the corrected 12-degree guidepost is placed back in the cast. A 3mm guide sleeve is placed on top of the 3mm top part of the two-piece guide sleeve. Triad gel is used to form the surgical guide by adding it to the adjacent teeth, both the lingual and occlusal view, and the cleats on the guide sleeve. The surgical guide must be examined. Any triad gel extending over either end of the guide sleeve must be removed. I recommend disinfecting the surgical guide and the surgical site with betadine and an interproximal brush prior to reflecting the flap. To place the implant with this guide, an elliptical incision was made with refraction of the small full-thickness flap lingually. Often the flap will be held out of the way by the surgical guide. Because the ridge is very narrow, I'm starting with the 1.6mm guide sleeve insert in the 3mm guide sleeve and a 1.5mm drill. The 1.6mm insert is removed and replaced with a 2.3mm insert for the 2.2mm drill. Post-surgical cone beam radiographic images of the implant placement were evaluated with the Carestream software. The cross-sectional or buccal lingual view can be seen showing the thin layer of bone on the labial surface of the implant. A vista approach was used to augment the buccal surface of the alveolar bone over the implant. The labial surface was grafted with osteogen, 0.5 cc's of Puros, 0.3 ml of sterile water, and 50 micrograms of infused bone graft. The sites were closed with 5/0 nylon suture left in place for 10 days prior to removal. The same appliance used to replace number 23 was used to move the adjacent central incisor lingually into position during the period of osseointegration. A custom abutment was inserted after 3 months. The ISQ for the implant was 79. The occlusal view of this restoration and the adjacent tooth can be seen in this mirror shot. The prosthetics and the movement of the adjacent tooth were completed by Dr. James Soltis.